progress. Am I clear?
Yes, I can hear you.
Okay, fine. So let's start then, because it's 5 minutes past 8 now. So good evening to all the participants who will be participating today in this session. And I would like to warmly welcome all of you to the monthly neonatal clinical update organized by the Ceylon College of Neonatologists in collaboration with Perinatal Society of Sri Lanka. So I'm really honored to have the opportunity to introduce the guest speaker for the day. She is, most of you might be knowing her, and she is Dr. Chamila Iroshini, who is one of our senior colleagues, served for a number of years in Teaching Hospital Batikalo, as well as in Teaching Hospital Anuradhapura, as a consultant neonatologist, following completion of her post-MD local training here in Sri Lanka. Currently, she is working as a neonatal clinical fellow at John Radcliffe Hospital, Oxford, in United Kingdom. So she will be today talking on a very important topic, that is neonatal hypoglycemia, which is a very common clinical scenario we encounter in our day-to-day practice as doctors and nurses and anybody else who is involved in taking care of neonates. So therefore, I would cordially invite Dr. Chamila Iroshini to commence her talk today on neonatal hypoglycemia. Over to you.
Thank you, Sangeeta, for your kind introduction and having me today. Can you hear me?
Yes, we can clearly hear you.
Okay, good evening all. I'm going to talk about the neonatal hypoglycemia today. I'm sure you all know about it. It is a very common condition when it comes to neonates. And also it is most controversial area when it comes to management of hypoglycemia. So I thought it is worth to refresh your knowledge and discuss of management and what we are practicing now, and whether we can change our practice according to the new evidence. So why hypoglycemia is so important? It can cause poor neurodevelopmental outcome in babies. So as a neonatal team, we have to minimize all these risk factors which can cause poor neurodevelopmental outcome. Not only the neonatal mortality, we have to take measures to prevent the neonatal morbidity as well. I hope you can see my slides.
Yes, we can see that.
Okay. So during my, I'm going to talk about, in my presentation, I will talk neonatal glucose homeostasis, clinical features and risk babies, glucose monitoring and management of transient hypoglycemia, investigation and management of prolonged hypoglycemia. So moving into glucose homeostasis in newborns, fetus obtains 60 to 70% of its energy from glucose. As we all know, babies get nutrition from maternal circulation. So all fetal glucose derives from maternal circulation by facilitated diffusion. Therefore, the fetal plasma glucose concentration is about 70 to 80% of maternal circulation, and always its fetus glucose concentration is depend on the maternal glucose concentration. It is proportionate to the maternal concentration. So you can see in this picture, glucose and amino acids and ketones can cross the placenta by facilitated diffusion, but not the insulin. That is important because insulin need to be produced by the fetus by its own. So when there is excess glucose, it is stored as a glycogen in fetal organs such as fetal liver, lung, heart, and skeletal muscles. But most of the glycogen is made and stored in the last month of the third trimester. Let's see what's happened when the baby is born. When baby is born, the cord is clamped. So then stop the glucose supply to the newborn. So newborn has to produce its own glucose by himself. But insulin levels remains the same because it takes time to reduce. Therefore, when the baby is born, when the cord is clamped, baby's glucose concentration goes down to its lowest level around 1 to 2 hours of age, that is around 25 to 40 milligram per deciliter, as you can see in this graph. So if you check the baby's glucose around 1 to 2 hours of age, obviously you can get a low glucose value. So therefore, we have to avoid checking the baby's blood sugar around this age. Otherwise, baby is sick or having any symptoms of hypoglycemia. So usually we check the baby's glucose concentration, glucose level around 3 to 4 hours of age. So when it comes to this low level, counter-regulatory hormones comes into action, such as catecholamine, glucagon, corticosteroids, and it increases the glucose concentration in the plasma by glycogenolysis and the gluconeogenesis. So glycogenolysis is the glucose production by glycogen breakdown, and glucogenesis is production of glucose by precursors such as amino acid, glycerol, and lactate. So after this period, newborn is make its own glucose, and concentration increases slowly to its level of 65 to 70 milligram by 3 to 4 hours of age. So this happens even without any intervention. This can happen spontaneously in healthy newborns, but sometimes in risk babies, they may need intervention like feed. So in 1986, they have done a study of a set of IUGR normal newborn babies. They have kept these babies fasting, and they have checked the glucose concentration of the babies, and they have found these similar findings. The glucose concentration has come down to its lowest level around 1 to 2 hours of age, and then it stabilizes around 45 to 50s by 3 to 4 hours of age. This initial drop in blood glucose concentration may be an essential step in activating physiological process that necessary for postnatal survival, like promoting glucose production by gluconeogenesis, stimulation of appetite, adaptation of fast feed cycle, enhancement of oxidative metabolism. So that's why we don't have to intervene this low glucose level, because it is physiological process. So in healthy newborns, we have to expect this low glucose level around 1 to 2 hours of age. So as a natural protector mechanism, newborn babies can utilize ketones as a precursor of their energy production. So they are protective from this low glucose level at around this age. So a little bit of the mechanism, how to maintain the euglycemia in their body. So as I told you, we in the body we have adrenaline, cortisol, glucagon, growth hormone, and TSH. These hormones promote the endogenous glucose production by glycogenolysis and the gluconeogenesis. And also it promotes the lipolysis and lipid oxidation, which cause increased production of gluconeogenesis. And also same time insulin goes down and it causes peripheral reduction in the peripheral glucose utilization, and also it promotes the endogenous glucose production. And finally, it stabilizes the glucose level in within the normal range. So this is, we all know the insulin is produced by the beta cells of the pancreas. So this beta cells, when there is a high glucose concentration, glucose enters into the beta cells, and it increases the glycolysis and increase the production of ATP. With the increase of ATP dependent potassium channel activated, and it causes membrane depolarization and calcium influx. That is then production of the insulin. So insulin goes up when there is a high glucose concentration in the body. So that is the normal physiology. So moving into definition of hypoglycemia, can anybody tell me what is the definition of hypoglycemia? Do we have a definition for hypoglycemia? Okay. Okay, no one wants to talk?
We actually don't have a proper definition of hypoglycemia as far as I know. According to the WHO, we have a working threshold for management of hypoglycemia, but there are some other concepts associated, so coming into exact definition might have been difficult probably.
Yeah, great. Yeah, that is actually we don't have a universal definition for hypoglycemia. That's why I told you this is a very controversial area when it's come to definition and the management of hypoglycemia. But we know hypoglycemia is a drop of blood glucose level below an accepted threshold for the age of the baby. But we know that there is a number called 47 milligram per deciliter. Earlier we know if it is less than 47 milligram per deciliter, we call it as a hypoglycemia. But this magical number came from one study which was done in 1988. They have studied IUGR set of IUGR babies less than 1.8 kilos, and they have followed up those babies after checking their blood glucose in initial period, and they have got that impression like if the baby is less than 47 milligram per deciliter of sugar in initial period, they had poor neurodevelopmental outcome at the age of 18 months. So that's how that 47 number came to practice. So hypoglycemia, there can be transient or persistent hypoglycemia or symptomatic or asymptomatic. So in the case of symptomatic hypoglycemia, the main aim is we have to avoid babies getting symptoms because it causes the worst neurodevelopmental worst neurodisability. So that's why we want to identify the babies who are having hypoglycemia before they comes into symptomatic. When we go into transient hypoglycemia is low sugar level which usually lasts for less than 3 days, but rarely it can persist up to 7 days. Persistent and recurrent hypoglycemia implies which require prolonged management and pharmacological intervention, which lasted more than 7 days. So coming into causes for transient hypoglycemia, I think most of these causes we know. So it can associated with changes in the maternal metabolism, infants of diabetic mothers, intrapartum administration of glucose. When we talk about these three conditions, this is mainly due to high maternal glucose concentration. As we talked earlier, baby's glucose concentration depend on the maternal glucose concentration. Therefore, when the mom is having high glucose concentration before the delivery, baby also having high glucose concentration, and the baby's insulin production is high because of this high glucose. So when the baby is born, cord is clamped and the glucose supply is stopped, and then baby's glucose concentration goes down as there is a high insulin concentration. That's why mainly infant of diabetic mothers, they get hypoglycemia. Sometimes they get severe hypoglycemia. And drug treatments such as beta blockers and the oral hypoglycemic agents also can cause neonatal hypoglycemia because they cause the placenta and cause increased insulin production and increased insulin sensitivity. When it comes to premature babies, as I already told you, that the glycogen stores storage happen in the last trimester, last month of the third trimester. So obviously in premature babies, they don't have much glycogen stores. Therefore, they are more vulnerable to hypoglycemia. So when it comes to IUGR babies, so we know IUGR means less than 10 centile. So they have a lot of risk factors to get the poor neurodevelopmental outcome. So one of the reasons is hypoglycemia. In that case, we have to prevent hypoglycemia in IUGR babies. We have to be very cautious when we are managing IUGR babies, because they already have a lot of risk factors for neurodisability. So these babies can have hypoglycemia due to so many reasons. Those are the failure of counter regulation of the hormones and immaturity of the enzyme system, which promote the gluconeogenesis and glycogenolysis. And also their adipose tissue stores are very minimal, and also they are hyperinsulinic, and they have a higher sensitivity to insulin. When we consider birth asphyxia, infection or sepsis babies, hypothermia and hyperviscosity, their glucose utilization is high. Therefore, they are more prone to get hypoglycemia. Very rarely, we can have erythroblastosis fetalis and congenital cardiac malformation. And those babies also, they can have hypoglycemia. Okay, when we come to risk factors, who are the babies we screen? I don't know whether we have nurses. Are there any participants, postnatal nurses?
Yes, some of the nurses are participating.
I just want to know, usually we monitor the babies in the postnatal wards. Who are the babies we usually screen in the postnatal wards? මිස්ලා කවුරු හරි ඉන්නවා නම් කියන්න පුළුවන්ද? Okay, so according to the guideline in our country, in Sri Lanka, I think we monitor the babies with IUGR, that is according to our guideline, I think less than 2.5 kg. and preterm babies, infants of diabetic mothers, and the guideline, it says infants of mothers who are taking beta blockers, but I don't know whether we are monitoring those babies. Chitma, do you know whether we are monitoring those babies?
Well, actually, we are mentioning, but sometimes we might miss because they are understanding about the beta blockers. I think it should come from the doctor's end. So we might miss some proportion. I agree.
Yeah, and here actually I have seen a lot of mothers who are taking mainly labetalol, but I don't know whether we are using labetalol in Sri Lanka for the control of blood pressure in moms. Maybe that is the reason we are not monitoring those babies. But I have experienced here a lot of babies goes into severe hypoglycemia when the mother is taking labetalol, and also when the mother is having diabetes. So I think it's a risk factors for hypoglycemia. So according to the AAP guidelines, they monitor the babies with who are small for gestational age, preterm, infants who are born to mothers with diabetes, and large for gestational age. But in here, UK, we also monitor the babies whose mothers are on beta blockers. So when we come to clinical features, actually these clinical features are very vague, and they are very non-specific. And also within first 48 hours, we rarely see the clinical features of hypoglycemia. So we can miss the hypoglycemic babies because they are asymptomatic. So when we think about the clinical features, they can be due to neuroglycopenia, or it can be due to increased sympathetic activity. Abnormal crying, irritability, seizures, apnea and cyanotic spells, jitteriness and tremors, lethargy, stupor, hypotonia, limpness, and feeding difficulties. Those all can happen due to neuroglycopenia. And sweating, hypothermia, tachycardia, grunting, tachypnea, these features are mainly due to increased sympathetic activity. So moving to methods of checking blood glucose, I know that in Sri Lanka, we use point of care machines, that is glucometers. So we have bedside testing as well as continuous interstitial testing. Nowadays, there are a lot of studies going on regarding this continuous interstitial monitoring, because it is very useful when we are managing extreme preterm babies to avoid the fluctuation of glucose concentration, because especially in preterm babies, they can go into hypoglycemia as well as hyperglycemia. So we have to maintain the glucose in a euglycemic state to prevent the to get a good outcome. So still this continuous monitoring is under study level, because it is not reliable in the low levels. So in the point of care machines that we use in Sri Lanka, like glucometers, also they are not reliable. They don't show reliable value in the when it comes to low levels. Also, whole blood glucose is 15% lower than the plasma glucose level. So in these glucometers, we measure whole blood glucose. And also venous level is 10% lower than the arterial level. The other thing is we usually, when there is a low glucose value, when we get it from the glucometer, we have to send the blood sample to the lab to confirm. So when we are sending these lab samples, we have to send it quickly, and we have to inform the lab before sending the sample for the to the analyze it quickly. Otherwise, it can drop the glucose 6 milligram per hour by RBC glycolysis. So in the lab, we use glucose oxidase or commercial glucose oxidase immobilized electrodes, and they measure the plasma glucose concentration. That is the very accurate and reliable method. And when it comes to this point of care measurements, glucometers, they are not very accurate. And there are studies, they have done the studies comparing the several glucometers and found that glucotrend and the precision glucometers have the greatest sensitivity and negative predictive value. So in our setup here, UK, we use these precision glucometers for continuous monitor, not the continuous, when they need a frequent monitoring of blood glucose. But here for the screening and monitoring, we use the blood gas analyze method that is also reliable as a lab method. So almost always we use blood gas analyzer method. But I know in Sri Lanka, we don't use blood gas machine for monitoring of glucose. I don't know why we are not using. Anyone has any idea why we are not? Are we using it or do we use it currently?
Well, Chamila, we look at the blood sugar value when we're doing the blood gas, but one thing is the blood gas is limiting facility at the moment in our country. So that is one thing. But sometimes we see the discrepancy with the glucometer. So actually we have to do one more blood start the investigation. That means the capillary blood and the blood gases to prove that difference. I think sometimes even in our unit, what we have seen is it's not similar in each and every situation.
Maybe our calibration or something may be wrong, because as you know, in here we monitor electrolyte, glucose and everything in the blood gas, because I thought we are spending a lot of money for these blood gas machines cartridge, but I think we are just that is my thought. Are we utilizing it effectively? Maybe future we can use it. At the moment, I know there are no cartridge and there are a lot of issues, but maybe future we can use this blood gas analyzer method for glucose monitoring. I think it's because it's the reliability and I think cost wise also maybe it's effective. So this is the precision glucometer that we using here. That is only for babies who need frequent monitoring. So when we move into management of hypoglycemia, I thought it's better to talk management by case basis. Otherwise, it's difficult to get into your brain, and also you may feel sleep. So I'm happy if somebody can answer, especially if we have nurses. So when we have IUGR baby less than 10 centile, born by normal vaginal delivery and good condition, and baby is active and well appearing, and mom wants to breastfeed. So how do you manage this baby? I'm just asking the basic management. What are we doing in the postnatal wards? කවුරු හරි මිස්ලා ඉන්නවද ආන්සර් කරන්න කැමති? මං
Chamila, I think the audience is muted. Deepa, can we make them to speak, or what we can do?
Okay. So that means they can't use their mics, no?
No, yes, they can only send their questions to Q&A.
Okay. Okay. So so when there is okay, then I will go to the case. So this is a risk category baby. So when we have IUGR baby less than 10 centile, so this baby need a glucose monitoring. So initial steps are we have to dry and put a hat. Obviously, we have to ensure the normothermia and place in skin-to-skin contact with mother to ensure the normothermia. And when it comes to skin-to-skin contact, I know this is a little bit deviation from my topic. Are we practicing skin-to-skin contact, Dilani?
Yes, we do.
That's good, but actually I know that nurses can't answer, but I have worked in a lot of peripheral centers like Badulla and Batikalo. I think there are a lot of practical issues that we can't practice the skin-to-skin contact like in UK, like these countries, because we have minimal facilities. I think our beds are also limited. When I work in the Batiklo, I have seen most of the normal delivered mothers are in like in the floor. They don't have even bed. So in that case, I think we can't practice this skin-to-skin contact. And also here we have this adjustable bed, but I think we don't have those kind of facilities in Sri Lanka. And also here the important thing is both parents are involving in this skin-to-skin contact. I have seen a lot of dads doing the skin-to-skin contact just even just after birth. But I don't know whether we can practice it in Sri Lanka. So managing this baby, so ensure the most important thing is ensure that baby is fed within the first 60 minutes. So next we have to check the baby's pre-feed sugar. So we have to avoid checking the blood sugar within first 1 to 2 hours. So usually we check the second pre-feed, that is around 3 to 4 hours. So if sugar is 38, so I thought if we can answer, it's maybe better, but now I know we can't answer the question. So if sugar is 38, what do you think? So do you need intervention here? So if sugar is above 36, what we practice here is encourage to continue feeding and breastfeeding support and recheck the sugar next pre-feed, that is again 2 to 3 hours time. I think in the Sri Lanka also, according to our guideline, if sugar is above 36, we do the same. We encourage to continue feeding and increase the, we ensure that we give the breastfeeding support. And I'm very happy and I'm very proud of our mothers and the postnatal nursing staff and the midwife regarding the breastfeeding thing, because in this setup, breastfeeding is not happening here, it's properly. So, but Sri Lanka, we have that opportunity to promote the breastfeeding, and it is, I think they are doing an amazing job there. So our main aim is support the breastfeeding, then the recheck sugar next pre-feed. So if it is still above 36, according to the UK guideline, we stop monitoring. So only we check twice. If both pre-feed sugars are above 36, we stop monitoring, but we make sure breastfeeding is established. Breastfeeding, here actually, most of the time, they establish it, maybe sometimes we use formula or express milk. So according to the Sri Lankan guideline, we repeat sugar in 4 hours, even though there are 2 consecutive values more than 36. According to the Sri Lankan guideline, we repeat sugar in 4 hours time and then 6 hourly for 24 hours. I don't know whether we need to monitor. Is it safe to stop at 36 or continue monitoring is needed? What do you think, Dilani?
So what in our setup, what I'm practicing is what you said, Dr. Chamila. So you usually monitor 2 blood sugar values. If those are normal, we tend to stop monitoring. If the baby is clinically stable and we are happy with other parameters of the baby.
Yeah, I think main thing is we have to establish the breastfeeding. If we are happy with the feeding, I think we can stop the monitoring safely. But I don't know whether other centers they are practicing the same. But I think it's maybe unnecessary for monitoring 6 hourly for 24 hours. But it depends because this management of hypoglycemia, it's very different from countries to countries and as well as centers to centers. So moving to second case, so diabetic mother, macrosomic baby, but active and feeding well. So the baby's first pre-feed sugar is 22. In that case, what is your next step? So if it is 22, that means it's between 18 and 36 milligram. So if it is between the 18 and 36 milligram, here what we practice is we have this 40% oral dextrose. So we give 40% oral dextrose, that is the dose is 200 milligram per kg. That is so easy to give, just a buccal preparation. So we have to apply into the baby's oral mucosa and continue feeds and recheck next pre-feed sugar. If that sugar is still between 18 to 36, repeat glucogel and continue feed. So I will talk about this glucogel later in my slides. So I think it's new to Sri Lanka, but in most of these countries they use glucogel for managing asymptomatic hypoglycemic babies, especially when their sugar level is between 18 to 36. So when the next sugar is more than 36, here we monitor babies until they get 2 consecutive values more than 36. If it is less than 36, the third pre-feed value is still less than 36 or in between 18 to 36, then we consider admitting the baby to the neonatal unit for IV fluids. In that case, we admit the baby, get the IV access, start 10% dextrose, 40 to 6 milligram per kg per minute of concentration, the dose, and we do the hypoglycemia screen. And in that case, consider septic stream and antibiotic, but we continue feeding. And according to the guideline in Sri Lanka also, the management of this category between 18 to 36, it says continue breastfeeding and recheck the sugar after before next pre-feed. And if it is still 36, above 36, then continue the breastfeeding until we get the 2 consecutive values more than 36. But after that, monitor 6 hourly for 24 hours. So the difference between our guideline and the Sri Lankan guideline is this dextrogel. So moving to next scenario. So this if late preterm baby, active and well, good sucking, blood sugar is 17. So how do we manage this case? That is less than 80 milligram per deciliter. In that case, we have to admit this baby to neonatal unit. So all the babies less than 18 milligram per deciliter, and if there is any symptoms, we have to admit the baby to neonatal unit for IV 10% IV dextrose. But while we are arranging the admission to neonatal unit, because it takes time to arrange the admission and obtain the IV access, therefore, here we use dextrogel again in that case. before admitting, we apply the dextra gel and then admit the baby to unit to prevent the to improve the glucose concentration of the baby. So in these babies, we have to give a 10% dextrose bolus, that is 200 milligram per kg equal to 2 ml per kg. And then followed with the IV 10% dextrose infusion. So usually start with 4 to 6 milligram per kg per minute or 60 ml per kg. And then if the baby needed the IV glucose bolus, then we have to check the sugar after 30 minutes. And also we need to take the hypoglycemia screening and consider sepsis, and also important thing is continue breastfeeding. So what is the important thing of continuing breastfeeding is breastfed babies are able to produce ketogenesis. They produce ketones by ketogenesis, and they can use it as an alternative fuel for energy production. So that is only with breastfeeding. Therefore, even with IV fluids, we can continue the breastfeeding, and we must continue breastfeeding. So when we, as a summary, so when there is a pre-feed blood sugar more than 2 millimole per liter, that means 36 milligram per deciliter, we follow the pathway of feeding. And if it is between 18 to 36 milligram per deciliter with no any abnormal sign, that is asymptomatic, we use dextra gel. And if it is less than 1, that is less than 18 milligram per deciliter, we use IV dextrose. So when it comes to management of symptomatic hypoglycemia, as I have discussed this already, so admit to the neonatal unit, IV access, and start IV dextrose following after bolus. And we have to always take the blood sample to lab to check the blood glucose, and also insulin, C-peptide, free fatty acid, and ketones. So these are the hypoglycemic critical sample: lab glucose, insulin, C-peptide, free fatty acid, and ketones. In managing of symptomatic or severe hypoglycemia, if there is a delay in getting IV access, you can use IM glucagon 200 milligram per kg. So this is again the flow chart of how we manage the babies here. It's the same thing that I have mentioned. If blood glucose level is more than 2, then establish with the feeding. If not, goes to the other flow charts like buccal dextrose. And then if it is less than 18, again admitted and starting IV dextrose. The same thing. So I just want to introduce this glucogel. This is a glucogel or dextra gel. This is 40% dextrose, and this is very. I think this is inexpensive. Even we can use maybe in future we can use this in Sri Lanka. There are a lot of studies, they have done a lot of studies regarding this 40% oral dextrose gel with some mixed results. But this is, as I told, it is inexpensive and does not require expertise. Here actually midwife give this even without asking doctors. They have the guideline. When the baby's sugar is between 18 to 36, they give the glucogel according to the guideline. And it always prevents the admission to neonatal unit and avoid venous access. This dextra gel, regarding this dextrose gel, I have found this study which was done in India recently. This article has published in this year, April, And I thought this is a similar setup to our setup because this has done in India. It was a randomized clinical trial. They have studied the two groups of babies giving dextrogel. So their background was the hypoglycemia affects 5 to 15% of neonates in the first few days of life, and up to 40% of risk neonates need intravenous fluids to stabilize the blood sugars. These values they get after doing the audit in their units. So they have found that 40% of risk neonates need intravenous fluid to stabilize blood sugars. So even though asymptomatic hypoglycemia is, if we think asymptomatic hypoglycemia, it is not benign. It is also can cause visual motor impairment, executive dysfunction, and impaired neurodevelopmental outcome at 2 to 6 years of age. And untreated hypoglycemia or delay in the treatment of hypoglycemia has irreversible long-term consequences such as seizures, microcephaly, and cerebral palsy. So on the other hand, admission to the neonatal unit, mother-baby separation negatively affect the breastfeeding by the fluctuation in blood sugar levels, and also it can cause complication of IV access. Therefore, with this background, their study aim was to check the efficacy of 40% oral dextrose gel along with the breastfeeding for treating asymptomatic hypoglycemia over breastfeeding alone in reducing NICU admission for intravenous treatment. Their current practice also similar to us. They use breastfeeding in the group of 8, the sugar between 18 to 36. So they have divided babies into two arms, dextrogel group and the control group, and they have followed their guideline. And finally, they have found the rate of treatment failure that is in the dextrogel group and the control group is respectively 17%. That is, treatment failure in the dextrogel group is 17, that is 11.5%, and the control group it is 55, that is 40%. So p-value is less than 0.001. So there is significant difference between this group, and they have concluded the study that use of 40% dextrogel can reduce the neonatal unit admission and IV access. Okay, so this is the management part of transient hypoglycemia. I don't know whether we can apply this management to our setup, but I think this dextrogel is, we have to think about dextrogel because it is not that expensive. In that case, we can prevent admission to our units, but I think better to, if someone is interested, and better to do an audit and see how many babies need to be admitted because for the intravenous dextrose, and then we can think about applying this to our setup. So moving to causes of hypoglycemia, I'm not going to talk detail about these things. So including for the causes for persistent hypoglycemia, there are a lot of causes. Main thing is hyperinsulinemic hypoglycemia. Apart from that, there are a lot of hormonal deficiencies such as ACTH, cortisol deficiency, growth hormone deficiency, and other enzyme deficiencies like glycogen storage diseases, glucose 6-phosphate, and also fatty acid oxidation defects, and some drugs. And there are a lot of other miscellaneous causes like infection, congenital heart disease. Among these causes, most common thing is hyperinsulinemic hypoglycemia. So according to the if you think about the hyperinsulinemic hypoglycemia. It is recurrent persistent hypoglycemia, more than less than 2.6 in babies more than 48 hours old. And also when the babies are more than 7 days old, and if they need a glucose concentration more than 15 milligram per kg per minute, we have to, those categories we have to screen for persistent hypoglycemia. So first we have to establish the diagnosis. In that case, first we do the insulin and C-peptide, beta hydroxybutyrate, plus plasma-free fatty acid, plasma lactate, and urine ketones. If ketone is positive, then we check the lactate. If lactate is high, this goes into urine. We check the urine organic acid and reducing substances. It can be due to gluconeogenesis enzyme defect, so organic acidemia. And if the baby is ketotic and lactate is low, then it goes to endocrine problems like glycogen storage diseases or ketotic hypoglycemia. And if baby is non-ketotic, and then we check the free fatty acid. So free fatty acid is, baby is non-ketotic and free fatty acid is high, then it is free fatty acid oxidation defects or carnitine deficiency. If non-ketotic and insulin is high, then it goes to hyperinsulinism pathway. So if the baby is hypoglycemic and insulin is detectable, that means insulin is high and baby is hyperinsulinemic. So how do we manage these hyperinsulinemic babies? When there is a hyperinsulinemia, we have to maintain the blood glucose level more than 3. So we have to increase the glucose infusion rate sufficient to maintain the normoglycemic level, that is more than 3. And we have to monitor and wean IV dextrose according to the glucose value and establish the enteral feed. And if when the baby is transient to full milk feed, we can monitor and can stop the monitoring. But rarely some babies need special advice from the endocrinology team to further investigation and for further treatment like hydrocortisone and glucagon or trial of diazoxide. So if you have a baby with a hyperinsulinemic hypoglycemia, better to take the endocrine advice and manage the baby accordingly. So I think we all know how to calculate the glucose infusion rate. I don't want to go through that. So prognosis, we all know the severe prolonged hypoglycemia in the neonatal period can have devastating outcomes, but there are no studies that to prove these poor neurodevelopmental disabilities. There are some studies that says that this hypoglycemia can cause poor neurodevelopmental outcome, but there are some other studies shows there is no significant difference between the normoglycemic and hypoglycemic babies when it comes to asymptomatic hypoglycemic babies. So most studies outcomes are inconclusive, but some studies shows recurrent prolonged severe hypoglycemia cause 25 to 50% of developmental disabilities. There is a study published in 2012, and this is a prospective study, included preterm infants more than 32 weeks gestation. And in that study, they have found no difference in developmental or physical disability at the age of 2 years between the normal babies, normal healthy babies, and the low glucose babies. And also they found at the age of 15 years, no difference in development of IQ scores between the two groups. So when it comes into hypoglycemia, monitoring management and also outcome is very controversial. So thank you. And any questions? I'm happy to answer if there is any question. And also, if are there any senior neonatologists?
Well, Chamila, thank you very much for your informative presentation. It was very useful. And I think you highlighted the main deficiencies which you have noted in our country when you are working. One thing is the not applying the blood gas monitoring. I think though the resources are limited, so sometimes with the optimal calibration and other using the facilities which is available, which we might able to enhance the monitoring of blood sugar using the blood gas. The other thing is the strengthening of the monitoring while reducing the workload. So as you clearly mentioned, as what Dilani practicing also, we are also doing very minimal monitoring, like what you are doing in your in the UK setup. So it's mainly go for 2 sugars, because otherwise we are unnecessarily overloading the work for the nursing staff. So we should think about it. But the important thing is ensuring the good breastfeeding. So for that, we need to support these mothers for breastfeeding, because that is very important. So if you are not ensuring the breastfeeding, then it will be a persistent or recurrent hypoglycemia. The other thing from your lecture, what I noted was the glucogel. Yes, I think it is definitely, it will be a very valuable thing to apply in our clinical setup, because we definitely need at least 1 or 2 babies need to admit to the ICU every day because of this low sugar. So I think we should think about it, and we'll discuss in our neonatal forum whether we can get down this glucogel to utilize in our setup. So we can make a guideline even for the nurses. If we apply that guideline and establish a proper guideline, then they can use as what they're practicing in the UK setup. So that is what I noted with where we can apply the things from your lecture, and it was very useful. Thank you again, Chamila, for updating us with your current knowledge.
Yeah, thank you. And I just want to highlight that dextrogel. It's, I think, only 8 pounds or something. It's not too expensive. So maybe in future we can think about that. And also I thought, as I mentioned, if you can do some audit and see how much of babies admitted to the neonatal unit with the hypoglycemia, then maybe we have evidence that to practice it. Okay, thank you very much.
Yeah, thank you very much for that informative and very much clear talk on neonatal hypoglycemia, which was delivered by Dr. Chamila Iroshini. And yes, actually, I was also fascinated by the use of 40% dextrose gel, which is something really new for my practice. So thank you very much for introducing to that kind of a management for us as well. Hope that as Dr. Jitma and Dr. Dilani mentioned, hope that we will be able to at some point get 40% dextrose gel to get down the gel to our setup as well. So thank you again, Dr. Chamila, for that informative lecture. And all the participants also, I would like to thank for participating in our monthly clinical session. So we will wind up there. Thank you.
Sorry, Sangita, I think we have one question in the chat box.
Yes, there is one now, actually, yes. So there's question telling that we have seen CBS value is greater than CBG glucose value at some time. But once you said that blood gas analysis is accurate, what is the value we should get as most accurate? So I think this is something regarding calibration. Anyway, do you have any
Yeah.
idea, Dr. Chamila? Yes.
So, what what do they mean with CBS?
That means
Eh,
the probably the capillary blood sugar value,
oh,
which is in
capillary
line
blood
with the
sugar. That's
machine.
a
Yes.
point of care machine, and the blood
Yes.
gas.
Blood gas.
Yeah, yeah. In that case, actually, the blood gas machine value, according to our setup in the UK, blood gas machine is always accurate. But I don't know with the yeah, it depends on the calibration. If you are running a good calibration according to the machine requirement, I think blood gas machine value is reliable, because the capillary the point of care value can be varied. It can depend on the lot of factors. Sometimes even with the contamination with the alcohol, it can give a different value, wrong value. So I think blood gas machine is more accurate and reliable than the capillary value. But it's depend on the machine calibration and everything.
Yes.
Dr. Chamila, in Mahamodra, actually, we had a machine that we have used the blood sugar values in the blood gas machine, and it's almost like more or less equal to the capillary blood sugar value.
Capillary
So,
sugar values.
yeah.
Yeah,
So,
actually, these machines, the point of care machines, are less accurate in especially the low values, because they are made for this to monitor the diabetics patient. No, that's in high values, it's maybe accurate. It's accurate, but only in the low values, those machines are not accurate because they are made for monitoring of diabetics, even in the children and adults. Because there are no machines to check the neonatal sugar. So yeah.
Chamila, I have another question. You mentioned that it's very important to maintain the normoglycemia rather than having
Yeah.
fluctuations of hyper and hypoglycemia. So, could you please elaborate it further and tell me which situation you are referring to?
Hello.
Glycemia.
So I think it's interrupted in between your question, but yeah, I got that. So hyperglycemia, actually, I have read some studies, and in those studies, they says even if the baby get hyperglycemia during the neonatal period, in especially first 48 hours, it can cause poor neurodevelopmental outcome and the later stage. So I think I'm also didn't aware until that point, but I know in the extreme preterm babies, we have to be more vigilant when we are managing the hypoglycemia. We get a lot of precaution to avoid hyperglycemia, and we want to maintain in the euglycemic state. But yeah, I think it's because of it's still under studies, but it's important to maintain the normoglycemic rather than going into hyperglycemia or a hypoglycemia. Is that the question that you asked, Jitma?
Yes, Chamila. So the maintaining of normoglycemia, they
It's
are
important.
more
Yeah.
pressing than in our setup, isn't it? So,
Yeah.
what our setup is, usually if we have hypoglycemia, we are more alert and we are very keen to attend for that. But when you see hyperglycemia, so our interest is not that high. So that's why. So it's important to maintain the normoglycemia, not going for extremes, isn't it? The fluctuations are more. Yes, so we should avoid
fluctuations are more. Yeah, in studies also they have found these fluctuations are more harmful than even than the hypoglycemia. We have to avoid the fluctuation, and I think that's why we don't have to intervene when there is a if baby's asymptomatic and having a normal, like a low normal sugar level, just to monitor and establish the feeding. I think most of the time in our setup, we use formula in Sri Lanka. I have seen most of the time if the baby's sugar level is around 30s or 40s, rather than establishing the breastfeeding, we go for the formula. But I don't think we have to jump and go for the formula. We can still establish the breastfeeding and continue the monitoring.
Okay, thank you, Chamila.
Okay.
Okay. So Q&A box, there are no further questions, it seems. So probably we'll be able to wind up the session. And thank you again, Dr. Chamila, for that informative and very